Hello, everybody. Good morning, good afternoon, good night, because it's a global webinar and it's my pleasure to open it. And my name is Mike Posner. I'm the Medical Director, Nestle Nutrition Institute for Europe. And it's my great pleasure to share today our webinar with two distinguished speakers. But why we have organized the webinar, it's also the reason because we have organized this on the occasion of the World Prematurity Day, what happened on the 17th of November. In my opinion, it's a very important day. I would say for three reasons. First, it's really an acknowledgement to all of you, to all of your healthcare professionals taking care for the smallest ones that really need special attention. The second why I see this day important is also to create awareness for the parents, because the parents are confronted from a non-planned situation to a complete, maybe changing, life-changing situation to take care of a preterm baby. And the third reason for me why this day is important is to create awareness within the society that this 10% of the babies that are born preterm needs special investment, needs to have a special care, and needs to be treated differently. So with this inspiration, we have also organized the webinar for today. And I think we have two very interesting topics, because one thing we know that technology is moving, is developing, and we all speak about, this artificial intelligence, and can it help in the future? Can it help to improve the care of preterm infants? And then a second, we go to, I think, in my opinion, also for a very important topic, what is sometimes not so much in the focus, because sometimes we are focusing very much what we are doing in hospital, even from a nutritional aspect, but what is happening after discharge? So do these little ones, do they still need individual solutions, nutritional solutions? So I think that is just the intro for this nice webinar. And I'm not the most important person today, because the most important people are our two speakers. And that's why I move now on to introduce briefly our first speaker. And it's my really great pleasure to have Joe New here, professor from Florida, from the US. I think he's known, very well known, because he did a lot of research. I think he did a research training also in Switzerland, what is actually, the hometown, let's say, of Nestle, the home country of Nestle in Switzerland. I think I cannot mention all the publications, because then I would need this hour, because I saw that there's already 315 publications. But what I really find it very interesting, Joe, you are sharing your knowledge. You are very much involved in training programs. And what I also very appreciate is, the training program, what you organized within the Hippocrates. And I think this is, globally, you share your knowledge globally. I think, 20 countries, 15 countries you lectured. I think you are a well-known person, and that's why for me it's now really a pleasure to hand over to you for your first presentation to the topic Beyond the One-Size-Fits-All Guidelines for Nutrition, Precision of Nutrition with artificial intelligence, multiomics, and digital twins. The screen is yours.
Hello, it's a real honor for me to be able to talk to you about this very important topic, and that is nutrition for the sick preterm. Can we make it more precise? Here's my disclosure slide. I have no conflicts of interest that I will be discussing in this lecture. The agenda for the next 20 or so minutes is that I'm going to provide a brief historical perspective, talk about nature's precision. I will talk about artificial intelligence and machine learning. I'll provide a brief background on multiomics and then how we can mesh artificial intelligence, machine learning with multiomics to improve pre, perinatal, and neonatal care. And then I'll just briefly touch on the digital twin concept for precision neonatal nutrition. Let's start here. Nature already has outstanding precision for both the fetus and the regular term-born infant. In terms of babies who are still inside the uterus, there's an excellent regulation to provide a continuous supply of glucose. Protein is taken up at about 4 grams per kilogram per day, and lipids at about 3 grams per kilogram per day. In terms of the newborn, there's also precision. And this has to do with the baby who is breastfeeding from the mother and who has close contact with the mother. And here we can see something that's called the enteromammary system, which is an example of postnatal precision nutrition. The baby and the mother are close to one another. The mother has a mature immune system, whereas the infant still has an immature immune system. If the infant is exposed to certain kinds of microbes, then that infant may not be able to respond very well to those particular microbes because of the immature immune system. But the mother is able to respond. And so, with close contact between the mother and the baby, and if this baby is receiving breast milk from the mother produces an immune response to these potentially pathogenic microbes, and that immune response will then get into the baby through the breast milk. Now, when it comes to where we have been in terms of medicine and nutrition for the preterm baby, where we are right now in the future, these are a couple of topics I'd like to briefly discuss. When it comes to the past, much of the medicine that we've had for preterm babies provided the best guess of what is best. So, for example, we were very concerned with trying to feed these babies too quickly because of potential metabolic overload or overloading the gastrointestinal tract. So we provided a slow introduction of parenteral nutrition and enteral nutrition. Now, in the present time, we are basing our uh, therapeutic and preventative measures more on evidence-based approaches, for example, using clinical trials, retrospective studies, meta-analyses, etc. And so the efficacy and safety of more aggressive TPN enteral feeding certain amino acids and lipids formulations are aimed at the average. The guidelines are based on means. So, for example, the studies that we have been doing use Gaussian statistics, where we try to do what is best for the majority of the babies. But that leaves a lot of babies out. And so we are going into a new era right now, which is precision-based medicine that relies more on algorithms, where we have not a retrospective evaluation and response to what is going on in the baby. We want to be able to predict what is going on and provide a priori interventions. So let's talk about this a little bit. This is a very important graph that was produced in 1976 by our colleague Eckhard Ziegler at the University of Iowa. And in the columns, we see weeks of gestational age, and then we see weight, water, protein, lipid, and energy. I want you to look at the 24-week gestation premature baby. The amount of lipid in that baby's body is 0.1%. At 26 weeks gestation, it's 1.5%. So these extremely premature babies have almost no energy stores. And even at 26 to 28 weeks, it'll only take a day or two to utilize these energy stores. Premature babies require high amounts of energy. And here's an example that I like to use. Here's a very premature baby born at around 26 weeks gestation. This preterm baby requires approximately 120 calories per kilo per day if fed by the enteral route to get growth that is similar to that baby would be growing in utero. This 120 calories per kilogram per day equates to an adult Tour de France cyclist who needs 7,000 calories per kilo per day. And if we assume that this is a 60 kilogram rider, the 60 kilogram rider at 7,000 calories per kilo, 7,000 calories per day is getting the same amount as what this baby here requires. Now, what do we actually do? And historically, we've been very, very concerned about feeding babies too quickly, either by the parenteral route or by the enteral route. And as far as parenteral nutrition, amino acids, very early in the history of neonatology, were started in the first week of life and advanced very slowly in increments. Lipid infusions were started in the first week and advanced incrementally. Amino acids and lipids were frequently delayed or interrupted. And so it was very unusual if a baby was getting total parenteral nutrition to reach this full total parenteral nutrition that is required for growth in the first week or even 10 days after the baby's birth. What about enteral nutrition? Well, in terms of history, we were also very afraid to feed our premature babies. And one of the reasons for being very afraid to put food into the gastrointestinal tract is because we were afraid of this happening. This is a baby who has developed a necrotic intestine, and this baby actually died because of this necrotic intestine. And so many neonatologists were using excuses to withhold enteral feedings. And these excuses include low APGAR scores, umbilical artery catheters, apnea and bradycardia, mechanical ventilation, CPAP, the use of vasoactive drugs. And we also had this concept that TPN was available and we could actually get babies to grow on TPN. Well, the problem is that if we do not put food into the gastrointestinal tract, many bad things can happen to the gastrointestinal tract, including higher permeability, a poor development of the microbiome, and also increased susceptibility to injury. And so we have begun to recognize that these excuses, none of these were evidence-based. As time went on, we were able to get more evidence. And here's an example of what we are doing using retrospective observational and also prospective randomized studies. This is a paper that provides guidelines for enteral nutrition. This is enteral nutrition in preterm infants from 2022, and this is a position paper from ESPGHAN committees on nutrition from invited experts. And so this is a set of guidelines that have been recommended for providing enteral nutrition for premature babies. And this is very reminiscent of something else that we have seen throughout history for adult nutrition, and this is something called the food pyramid. Well, the food pyramid also is aimed at the average individuals. So here we see in this food pyramid what we should be feeding in terms of rice and carbohydrates and vegetables and et cetera. But we've begun to recognize that these food pyramids and guidelines are really very helpful in some ways, but they leave many people out. And so a more precision-based approach is considered to be necessary. And why is this? Because we do not all respond the same to the same food intake. Here's a very interesting study that was published a couple of years ago in Nature Medicine. And the title of this paper was Human Postprandial Responses to Food and Potential for Precision Nutrition. And in this study, they evaluated over 1,000 twin pairs. And they tried to feed these twin pairs the same diet. And then they looked at responses postprandially in regards to blood triglyceride, glucose concentration, insulin production, and glycemic responses. But what they found was that even with the same food intake in twins, they saw differences in these responses. And they evaluated the microbiome in these infants, in these adults, and found that probably one of the major differences that led to these differences in response was the difference in the microbiome and the types of microbes that these twins were harboring. So more precision nutrition is required, and there are tools that we have available now that can help us. But what do we do in terms of our current precision-based approaches? In neonates, we titrate the caloric and protein intake depending on growth curves. And here we see some growth curves. We attempt to provide an intake intravenously or through a feeding tube that is commensurate to what these infants would be obtaining if they were still in the womb. We've tried to use baby's own mother's milk or bank donor milk. The former contains many protective bioactive compounds, but both baby's own mother's milk and donor milk require some form of fortification. But the precise amount is not clear for each individual infant. One of the things that we do is we try to follow growth curves. And when we follow growth curves, we can see if we are doing a good job or not by seeing faltering on the growth curve. But if we see faltering, one of the problems is that damage in these rapidly growing, highly susceptible individuals has already been done. So we need to develop something that is much more personalized and preemptive. And this is where precision personalized nutrition comes in. We need to recognize that this baby and this baby are very different individuals. One size does not fit all. And we get some poor outcomes that are associated with suboptimal early nutrition that is not precision based. We have some babies who develop intestinal dysfunction and injury because of this. BPD, ROP, growth failure may occur in these infants. And sometimes with overfeeding, we may actually get something called metabolic syndrome when these babies grow to be adults. Poor neurodevelopment is also a major problem. So, what is needed, and how do we go about providing more nuanced, personalized nutrition? Well, a more nuanced, precision, or personalized approach that considers the infant's previous and current environment, for example, maternal obesity, fetal under and overnutrition, antibiotic use, microbial environment affecting the microbiome, needs to be taken into account. This is not easy to do by just using our own brains and using our own judgment. A proactive, precision-based approach directed toward personalized needs for preterm infants that transcends a one-size-fits-all guideline-based approach is needed. So we are beginning to try to tackle this. And here's a very interesting paper that was published a couple of years ago, and this was from the UK. And the title of this paper was Identification of Variation in, Nutritional Practice in Neonatal Units in England in Association with Clinical Outcomes Using Agnostic Machine Learning. So agnostic machine learning is a type of machine learning that can help us take all kinds of features and put these features into clusters. And instead of looking at an entire population of babies that are less than 33 weeks gestation, for example, we can begin to cluster them using this kind of an approach. And this is one of the first papers using a large data set that tells us that we can probably cluster these babies and then begin to look at each one of these clusters more individually and provide nuanced nutrition for these clusters. So this agnostic machine learning, another name for it is unsupervised machine learning. And the way this works is if we have raw data, so here we have different kinds of fruits, and what we want to do is separate these fruits into different clusters. And we have certain types of algorithms that can do this for us and separate these into different clusters. We have recently done this in our group at the University of Florida, looking at babies with various forms of intestinal injury and dysfunction. And as you probably know, we have this problem that we are calling necrotizing enterocolitis that is really a very heterogeneous group of injuries. And so what we did in this study, we utilized unsupervised machine learning to cluster these babies. And here in the x-axis, we see 200 different babies. Here we see different features in these babies. And here's the clustering that is done. And we were able to find 5 different clusters using this machine learning approach. Well, we can do the same thing, the same type of clustering for babies to evaluate what is needed in terms of their nutritional intake. But in addition to just doing the clustering, we need to know what is going on within each one of those clusters. And we can use a technique called integrated multi-omics to do this. Now, you are probably all familiar with the microbiome, the genome, metabolome. Those can be very, very helpful for us to determine associations. But one of the things we need to do if we want to get more precise is to incorporate these together and integrate them into something called a systems biology approach. So instead of just looking at the microbiome, metabolome, or proteome, we integrate these and develop a system biology approach. And what this does, it tells us what is going on in the entire cluster. So if we compare these clusters, we can then get a much better idea of potential biomarkers that we can pull out and begin to utilize early to determine which cluster these babies are in and begin to think about how we can best nourish babies in an individual cluster. So let's put this together into the future approach. Clustering. We cluster a population into nuanced phenotypes from early clinical features using unsupervised machine learning. Each one of these clusters is then evaluated using a multi-omic approach to get this systems biology, which can help us discover biomarkers. And we can then evaluate those biomarkers to tell us how to best nourish babies within these clusters. But then we can even go a step further, and that is by using something called a digital twin approach. And we can develop a digital twin by utilization of a large data set that includes genomics, that includes multiomics, that includes features, clinical features. And then we take a physical baby and we input data into the digital twin And the digital twin learns from the physical twin and starts providing feedback. And that feedback can then be utilized for specific individualized nutrition in that physical twin. So this is where we were, where we are right now, and where we are going in the future. And I'd like to stop here with just a quick summary. Not all preterm infants are the same. In the future, we'll need to focus on a more personalized approach that accounts for specific gestational age and degree of illness and omic considerations. Artificial intelligence, machine learning, and multiomics are likely to play a role in developing this approach. Thank you very much for your attention.
So thank you very much, Joseph. I think you have seen our pre-recorded version, but you see that we are all there. So I think we have really the speakers lively there. But for some, transition reasons with Zoom, we have decided to go for the recorded version. But we will have a discussion afterwards, and that's why I really encourage you when you have, I see already questions coming in. So you have a chat button on your screen where you can really put your questions, and then we will have a panel discussion at the end of our today webinar. And please use this opportunity because then we can have a good discussion of the both topics together because use really the knowledge of the specialists here on the screen. Having said this and referring to my introduction, I would now move to the second speaker. And as I said, we have Professor Nadia Hayden here on the screen, lively waiting also for the live discussion later on. I think Professor Hayden is the head of the Children's Hospital in the University in Linz. I think she is pediatrician and neonatologist, and she has done a lot of, can even show you a little bit the CV. I think, again, more than 80 peer-reviewed articles. So I think she is very well known in the field of nutrition, especially in the field of preterm nutrition. And I still also remember studies that has been performed even then later on the importance of winning food and so on. I think a lot of activities. And she's not only an ASPECAN member, she's now the chair of the nutrition committee at the ASPECAN and another duty, I think, where they can really help the older HCPs to get a better understanding of nutritional aspects. And as I mentioned in my intro, I think it's really important. And there is a new discussion about this post-discharge feeding because I think still this vulnerable target group maybe have special needs and we need to meet them. So that's why I'm very happy that you have agreed to participate in our webinar today. And for the participants, just to let you know, you see now the pre-recorded version, just to be on the safe side that you can follow the presentation without interruption. I encourage you again to put your questions in the chat because then I see them via Slido that we can have at the end a very live discussion. Happy to put the presentation on screen. Thank you very much.
Welcome to World Prematurity Day 2024, and thank you for joining me. My name is Nadia Hayden. I am the head of the ASPECAN Nutrition Committee, and today we'll be discussing nutritional strategies for preterm infants post-discharge from the hospital. With medical advancements, many preterm infants now survive early birth, but they continue to have unique nutritional needs that require special attention to support their growth and development even after discharge. The guidelines we discuss today are the new ASPECAN guidelines, which will be published soon. ASPECAN stands for European Society of Pediatric Gastroenterology, Hepatology and Nutrition. And this society plays a leading role in creating standards that address the specific nutritional needs and health goals for preterm, term, and infants and older children. So one key area of the new guidelines addresses is the growth restriction in preterm infants. The guidelines define growth restriction with specific criteria primarily based on birth weight and percentile-based measures. Growth restriction is classified by a birth weight below the 3rd percentile or more than 2 standard deviations below the mean. Or, and that is new, it's a combination of 2 different guidelines, or the presence of at least 3 of the following parameters: a birth weight below the 10th percentile, head circumference below the 10th percentile, length below the 10th percentile, or a prenatal diagnosis of intrauterine growth restriction or fetal growth restriction, and certain maternal health conditions, such as maternal illness, pre-hypertension, or pre-eclampsia. And you can see here on the picture these 2 infants, one growth restricted and one appropriate for gestational age. And you will further see them with the yellow beanies. These are the growth restricted infants, and the blue beanies, these are the appropriate for gestational age infants. Here you can see how this new growth restriction guideline was defined. It's a combination between small for gestational age definition, which is a diagnosis that is made at birth and is defined as a birth weight below the 3rd percentile, and the definition of intrauterine growth restriction. This is a diagnosis usually made during pregnancy and related to infant size and several ultrasound measurements, such as arterial pulsatility index. And this combination now is the new definition of growth restriction that addresses both small for gestational age and intrauterine growth restriction and combines it. The new ESPGHAN guidelines also include new parameters to monitor growth. Growth monitoring in preterm infants involves specific parameters before and after the expected term. Until the expected term, we focus on weight, length, and head circumference using the Fenton growth charts. Post-term, we switch to the WHO growth charts to calculate length and weight for length set scores, which provide a standardized growth assessment. What are set scores? Set scores you can see here when you imagine that this is a normal population of preterm infants. And at 0, you see the mean of length or birth weight, for example, and -1 to the left is a set score that is -1 standard deviation below the mean. So this is the definition of set scores. The set score describes how many standard deviations a data point is from its mean. And this is a very helpful parameter to monitor growth. And there are also standardized WHO charts. You can see here the weight for length set scores for girls and boys. For girls, on the x-axis, you can see the length parameters, and the y-axis, you can see the weight parameters, and the charts are here, the set scores. 0 is appropriate growth, which is the 50s below, is related to the 50th percentile. -2 is correlated to the 3rd percentile, and below is out of the range. And here are also tables available where you can just have a look at the weight, and then see, depending if the infant is 1, 2, 3 set scores above or below, you can monitor growth with these tables. The desired weight gain, growth is related to weight gain. And this is a table that shows you the desired weight gain in different weight groups that guide the nutritional requirements of preterm infants. You can see here in this table, the more immature the infant is, the higher is the desired weight gain until term. These growth velocities reflect the intrauterine growth velocities. And now we also understand that the physiologic percentile for weight gain after birth is 1 percentile below the birth percentile. This is related to a higher proportion of total body water when compared to term infants. So this is the desired weight gain in preterm infants during their stay in the neonatal intensive care unit. After discharge, you have the switch from the Fenton to the WHO growth charts. You can see here a graph that combines the Fenton growth charts here on the left with the WHO growth charts here on the right. And you can see that at term, there is a discrepancy between Fenton and WHO growth charts. So it is the optimum is to switch to WHO growth percentiles or charts at 44 weeks of gestation. So the physiological growth is 1 Z-score below the birth percentile until term. And after term, use length or weight for length Z-scores and switch to the WHO percentiles at approximately 44 weeks. Enable catch-up growth with poor postnatal growth, and the goal is to achieve catch-up growth of approximately around 44 weeks of gestation. In the post-discharge care, nutritional balance is very important. So on the one hand, we should avoid undernutrition, and on the other hand, we should avoid excessive supply of empty calories, which can induce rapid weight gain with increased body fat deposition, which is a risk factor for insulin resistance that predisposes into development of later metabolic syndrome and increased risk from non-communicable diseases such as diabetes and cardiovascular disorders. Furthermore, catch-up growth with accelerated weight gain and crossing percentiles upright might be associated with altered fat distribution and consequences related to programmed metabolic or wrong metabolic programming later on in life. So this slide introduces a new timeline that captures the critical stages of growth and nutritional needs for preterm infants from birth through discharge and beyond. So you can see here on the left side, the timeline starts at birth and the stay in the neonatal intensive care units. And we distinguish between an adequate nutritional status at birth or growth restriction at birth. Then during the stay in the neonatal intensive care unit, we have again different growth patterns. We distinguish between adequate postnatal growth and growth faltering. And this leads to a nutritional status at discharge which is either adequate for gestational age, or we identify a nutritional status at risk. This is an infant that's lost a lot of weight or length due to their complicated stay in the neonatal intensive care unit and is at risk to develop further growth faltering. Or we have already infants that had a very complicated stay in the neonatal intensive care unit and suffer already from undernutrition, and they need special attendance. So if we have an adequate nutritional status at birth, our growth target after discharge is physiological growth according to the birth percentile minus 1 standard deviation. And if we have a growth restricted infant at birth, our growth target is to recover to physiological percentiles, which are defined as minus 2 SDs. And I'll guide you now to specific growth patterns in after the stay in the neonatal intensive care unit. So here the first growth pattern is adequate nutritional status at birth, and again you have this pattern that you have an adequate postnatal growth during the stay in the intensive care unit. And you lose a maximum of minus 1 SD. So your nutritional status at discharge is an adequate nutritional status, so no catch-up after discharge is required, and your growth target is normal growth. You just have to monitor the infants. Another possibility is if you have an adequate nutritional status at birth, infants might suffer from growth falterings, which is defined as a drop of more than 1 SD in the neonatal intensive care unit. And then you have the problem that you have a Z-score above or below -2 SDs. So catch-up might be required or is required. And then your post-discharge growth target is length and weight, to come back with length and weight for length to -1 differences from the birth percentile. So the goal for the growth target for infants with adequate nutritional status is to bring them back to -1 SD from their birth percentile. So they need close surveillance or nutritional support after discharge. It is not easy to monitor these new growth patterns, and I would recommend, for example, this growth jet calculator from Paddy Tools. Also, the SBGAN will provide a calculator soon. So here you can see very nicely, you insert, for example, gestational age, weight, head circumference, and length. And this growth calculator gives you information on what is the actual percentile and what is the actual Z-score of the infant, and also provides very nice information, for example, how deep your umbilical catheter is inserted, or other important things for preterm infant, for example, ROP exam or RSV prophylaxis. And here on the left-hand side, you can insert the actual date of birth, and then you can calculate also the actual Z-score, the date of birth, and you can also insert the actual date, and then you can calculate what is the actual Z-score and the actual percentile of your baby post-discharge. So what about the infants with growth restriction at birth? Again, we have two different possibilities. We have an adequate postnatal growth, and we have two possibilities. We have an infant that is discharged with a Z-score above -2 standard deviations, or an infant that is discharged with a Z-score -2 standard deviations. The ones discharged with appropriate nutritional status, they need no catch-up growth. And the other ones with the undernutrition that are below -2 SD, they need close surveillance because they are at risk to suffer from later growth faltering. Another possibility is that you have, again, a growth-restricted infant at birth that has additional growth faltering during their stay in the neonatal intensive care unit. So they lose a further standard deviation in addition to their already 2 standard deviations that are below the normal percentile range. So they are now, for example, -3 standard deviations. So they are at discharge, they are undernutrient and they need catch-up growth to come back to their percentiles. And these percentiles are the physiological percentiles. So this is a Z-score of -2 SD from the mean. This is the growth target for growth-restricted infants that have additional growth faltering during their stay in the neonatal intensive care unit. They need nutritional support. So which possibilities do we have to enrich nutritional density? Enriching the nutritional density of preterm infants' diets involve providing high-calorie, nutrient-rich feedings without overloading, with excessive volume. And this approach allows infants to receive the necessary energy and nutrients for growth without causing digestive overload, a common risk in preterm infants. It is essential to balance protein, fat, and carbohydrates to ensure that each calorie supports healthy growth. And here on the left-hand side, you can see several examples from discharge up to 4 to 6 months of corrected age. We have different possibilities differing from country to country. We have the possibility to fortify human milk. We have the possibility or the option of post-discharge formula or preterm formula. We can enrich standard formula, or we can use hypercaloric formula in this period of life. Feeding can be particularly challenging for preterm infants. Many experience feeding difficulties due to their neurological immaturity and the extensive medical interventions. They go often through the NICU, such as tube feeding or intubation. So we really violate the oral cavity. For example, 15 to 23% of infants born before 29 weeks are discharged on tube feeding due to these challenges. Feeding in preterm infants isn't just a physical act. It involves emotional and psychological factors that require an individualized approach. Addressing these feeding difficulties holistically helps to support the children's growth and development along with their well-being. So the time point of introduction of complementary food during the first year of life and in the discharge period is really important, a developmental step in preterm infants, but timing is the key. So preterm infants are physiologically different from full-term infants, so the timing must consider their corrected age and their neuromotorical readiness. Factors like the development of fine motor skills, including jaw control and swallowing reflexes, are essential for safe food introduction. So, for example, you can see here the extrusion reflex. This reflex has to diminish before you offer a spoon to the infant, because this reflex protects the infant from aspiration and from choking. And this usually disappears between the 4th and 6th month of corrected for gestational age. And then this is, for example, a sign when an infant is ready. So in term infants, the European Society of Pediatric Gastroenterology, Hepatology and Nutrition recommends to wean from breastfeeding or bottle feeding between the 16th and 27th week of life. And however, no recommendations are available for preterm infants, and it remains unclear what is the best time point for introduction of solids. The question is more or less driven by growth parameters and the neurological ability. And we have data from approximately 16 observational studies where infants were weaned between the 13th and 15th week of life, corrected for gestational age. And interestingly, the degree of prematurity was a major determinant for complementary food introduction, in terms that the younger or the more immature the infants were, the earlier complementary food was introduced. And we have also data from 3 randomized controlled trials. These are, one is outdated because this is from the area where enhanced formulas or fortifiers were not available, but the other 2 showed that the time point of introduction of solids does not affect growth. So this is an important conclusion, and it allows to choose the time point according to the neurological ability of the preterm infant. So solids should be introduced, not driven by growth or by time point or by age, for example. It should be introduced by neuromotoric readiness. And again, for this period, we have different possibilities how to enhance nutrients. So we have the possibility to, for example, to change the texture of solids adapted to the neurological development and the feeding skills. We have dietary strategies, for example, to add almond flour or pan-fry foods in olive oil, for example, to improve nutrient density. And we also we have modules to enhance energy and nutrient supply, but this needs the involvement of a dietitian or a nutritionist to help with the calculations for these infants. So next we'll talk briefly about two critical nutrients for preterm infants, vitamin D and iron. So vitamin D is essential for bone health, and iron plays a crucial role in brain development. So preterm infants are often deficient in these nutrients. So Asperger recommends to supplement them, and these are data from one of these trials where solids were introduced. And what you can see here nicely, that the total intake here on the left of vitamin D went down as soon as solids were introduced. And in parallel, the serum levels of vitamin D went down. So interestingly, although the infants were supplemented with an extra of 650 units per day during the first year of life, and what you can see here is that during the first year of life, more and more infant becomes vitamin D deficient, leading up to approximately more than 80% of infants with vitamin D deficiency when they were 1 year corrected for age, although they were supplemented with an extra of 650 units per day, in addition to their dietary daily intake. What about iron? Serum ferritin levels are used as an indicator of iron status in preterm infants and also in term infants. And by measuring ferritin, clinicians can adjust iron supplementation to match the individual needs of each infant, avoiding both iron deficiency and toxicity. And you can see here on the left-hand side, again, data from studies where solids were introduced in preterm infants. And these infants were supplemented with 2 to 4 milligrams per kilogram per day until solids were introduced. And you can see that the enteral intake went down as soon as solids were introduced. However, in case of serum ferritin levels, in contrast to vitamin D levels, serum ferritin levels did not went down. So also this shows in this table that iron deficiency here in red was a problem in the first 3 months after discharge, but not at the end of the first year. So it seems that as soon as meat is introduced, the iron supplementation or the iron supply is more or less sufficient. And it is important to supplement iron during the first 6 months of life, and then according to the individual needs of the infants. But as soon as meat is introduced, the iron supply seems to be very good. So to summarize, the key factors in supplementation include close monitoring and adjusting dosage according to the infant health, birth weight, and any other existing conditions. So for vitamin D, this means supplement for the first 12 months, corrected age for term, 400 to 700 units per kilogram per day in the neonatal intensive care units, and after discharge up to a maximum of 1,000 units per day according to the infant needs. And monitoring is absolutely indicated in high-risk infants. These are infants with a birth weight below 1,500 grams, with bronchopulmonary dysplasia, for example, or in infants which suffered from necrotizing enterocolitis. And the recommendations for iron supplementation: supplement for 6 to 12 months, supplement more in infants with a birth weight below 1,500 grams, 2 to 3 milligram per kilogram per day. And also in the late preterm infants, it is important to monitor and to supplement the iron intake during the first year of life. So, to sum up, we have explored the importance of tailored nutrition for preterm infants post-discharge with a focus on the new ESPGHAN guidelines. And these guidelines provide a framework for addressing growth restriction, managing metabolic health, and supplementing key nutrients like vitamin D and iron. So to sum up, the post-discharge management of preterm infant depends on the growth status at birth and growth in the early postnatal period up to discharge. So it is important if the infant is appropriate for gestational age at birth, and it is important how the growth trajectories are during the stay in the neonatal intensive care unit. Please consider that there's a new definition of growth restriction that combines SGA and IUGR. After term, monitor growth by length and weight for length Z-scores. The target for infants born appropriate for gestational age is to grow or catch up length or weight for length Z-scores to -1 standard deviations to their birth percentiles. So the key target or the growth target for these infants is the birth percentile, in contrast to the growth retarded infants with a growth restriction or with a growth restriction. Here, the growth target is the physiological percentile, which is defined at -2 STs in length or weight for length Z-scores. So two different growth targets depending on their growth status at birth. And there are various options to enhance nutritional density to achieve catch-up growth, human milk, for example, with human milk fortifiers, post-discharge formula, formula with a higher nutritional density, for example. And in terms of introduction of solid, there is no specific time point which applies safely for all of the preterm infants, and complementary feeding should be introduced following an individualized evaluation, namely based on the infant's development rather than corrected or postnatal age. So consider the neuromotoric readiness, it is important. The time point of introduction of solids in preterm infants has no impact on growth as long as it's before the 6th month corrected for age. And preterm infants are susceptible for early iron deficiency and late vitamin D deficiency, so supplementation and monitoring is indicated. So thank you for their attention, and I hope this overview has highlighted the significance of this specialized approach to infant nutrition. Thank you very much.
So thank you very much. So we are back on the live screen. You see all the three of us, Nadia and Joseph, and I think you are very active, what is very good. And I have here the questions, and some questions are voted, supported, and that helps me. And we'll start now with the most voted question, because I think as we have maybe 10, 12 minutes, maybe we cannot discuss everything. So I start with the ones that's, I think it's referring, Nadia, to your presentation, is how long a preterm formula should be recommended in the event there's no post-discharge formula available?
Well, this addresses a difficult question because preterm formulas are not everywhere available in the discharge setting. So we have to look at the country, what is available, and this depends on if post-discharge formula is available, fortifiers are available, or preterm formula are available. So if no post-discharge formula is available, you should use preterm formula as long as the infant catches up. If post-discharge formula is available, you should use post-discharge formula. Breastfeeding is always the best. So in case the mother is able to breastfeed, then you should fortify the breast milk, but as long as the catch-up growth is established, and that is the difference to the former guidelines who limited this with 52 weeks of gestations. But from the actual database, which is really very limited, we recommend to feed enhanced nutrients as long as catch-up growth is established.
Okay, thank you very much. And I think in the presentation were also some recommendations what you can do if there is something not available. But I think maybe the next question is also misrated. I think it's just Joseph, one for you maybe. How do we care for preterms that their muscles are HIV positive, not lactating well, and cannot sustain breast milk substitutes due to financial constraints? I mean, it's also a practical question. Maybe you can address this, Joseph.
Yeah, I think that it depends so much on the particular situation, the viral load. Certainly, if the viral load is extremely low, then there can be breastfeeding. If the viral load is high, then I think that we have to be very, very careful to not transmit the virus. We have been using the therapies, the pharmacologic therapies for babies who are HIV, whose mothers are HIV positive. And so I think it depends a lot on the individual situation. So one size does not fit all with this.
Yeah, thank you. It's a very difficult question, but thank you for trying, to give the directions. And I think maybe the next question you can choose is, I think it's interesting in the way that how is there a way to access the preterm baby before giving a formula? So how do you access a preemie before giving a formula?
This question is not really clear to me, sorry.
And I think is there a way that you analyze or you just you look at the behavior of the preemie, or what is there you measure something before you decide to go on a formula? So that's how I see the question.
Perhaps this also addresses the switch from tube feeding to
Might be there's one thing what you need to access. Is this the right time, or when is the right time?
Usually you can start when the infant has a certain grade of maturity, and this is usually around the 34th week of gestation when the baby has a coordinated sucking, swallowing, and breathing pattern. You shouldn't start before, and then you should primarily start with breast milk if available. And this is also, if breast milk is not available, then you can start with formula feeding. I hope this addresses the question.
Maybe in addition to that question, I think it's where it fits to that topic is, can a premature born baby at the 13th weeks suckle the breast? Is there a specific age where you say it's possible or it's not possible?
Sorry, Joseph, you want to answer, or should I?
Certainly, I think that I mean I have seen babies at less than 34 weeks gestation who just tend to be fairly mature and who are very vigorous, who are able to do very well suckling at the breast.
But when they suck from the bottle, a coordinated sucking, swallowing, and breathing pattern is not established usually before the 34th week, because the sucking on the breast is a self-demanded process, and the sucking from the bottle, if you turn the bottle around, it always drops, so the baby has not the same sucking pattern as on the breast. So you can give the baby to the breast or put the baby to the breast, of course, before the 34th week, and it will suck very fine. But bottle feeding should not be started before 34 weeks because it might cause feeding disorders, especially in very preterm infants.
Thank you very much. I'm just looking. I think maybe one where we get, so of course, some questions is, about prevention of neck. So maybe brief, Joseph, maybe the role of probiotics in preterm feeding and the probiotics in neck. And is there general, and there's a second question, the two questions about the role of probiotics in prevention of neck. I think it's a different, could be even an additional webinar, but maybe short.
Yeah. Yeah. So, Mike, I think you're absolutely right that this is a topic of at least one big webinar. But The way that I like to answer that question, and thank you for that question, by the way, is that there are at least 100, 150 different kinds of probiotics available. And so whenever somebody asks me, should we be using probiotics to prevent NEC, the first question that comes to mind is, which one are you talking about? And then when we look at the studies that are available are most of them are very, very weak in terms of prevention of any kind of gut injury in premature babies. If you put them together into a meta-analysis, you start seeing some suggestions that that probiotics are helpful, but which one? I think that's one of the biggest questions. And then what is the definition of what we are calling NEC? And I think that that's a question in itself that we have not yet answered. And hopefully in the future, we will be able to evaluate and cluster different forms of intestinal injury where we are no longer even calling a disease process necrotizing enterocolitis, which I think will be a major step toward prevention of some of these gut injuries that we are calling necrotizing enterocolitis. So bottom line is, I think the answer is still not there for any particular probiotic. I've been involved in a very large prospective randomized trial, and this is going to be evaluated by a peer review process in the near future, and hopefully we'll see a publication on that in the near future.
Maybe I take two questions. I think it's because this is very often addressed, and you can then choose. So what is, when you feed a preterm baby, what if the preterm baby has either, for example, constipation or a GERD, gastrointestinal reflux disease? How you handle this?
Well, constipation is something that is very subjective, and what many people do is they jump right toward giving glycerin suppositories or enemas, and I am not a very keen on doing that. I want to stay away from them as much as possible, and usually these premature babies do have some intestinal motility problems, but one of the best things to do is to make sure that you are feeding the baby, because if you don't put anything in, you will not have anything coming out. So that's point number one. I will very rarely use a glycerin suppository or enema. And the studies that have looked at this with routine use have shown no benefit for that practice. So that's the one side of things. The other side of things you're talking about is the gastroesophageal reflux. And so that's a big question in itself, because most of these babies will have some gastroesophageal reflux. Whether it is clinically significant or not is a big, big question. We used to think that apneas and bradycardias were caused by reflux. And studies have been done looking at reflux and the association or causal association between acid in the esophagus and actual impedance measurements in the esophagus. And only about 3% of these episodes that have been considered as reflux episodes that cause things like apnea and bradycardia are actually causally related, okay? So that's very important point to remember. Things that can be done are, if you're tube feeding the baby, prolong the tube feedings. That sometimes can be very helpful. Transpyloric feedings, if you think that this is really causing a lot of emesis, that can be helpful. So there are tricks that can be used.
Okay,
Yeah.
I think maybe Nadia.
For the post-discharge area, perhaps this addresses also to the formula that are on the market against constipation and reflux. And the ASBIGAN has published a paper on these mild functional disorders. What is the evidence for it? And what the literature shows is that there is, if you're not able to breastfeed, In the baby with gastroesophageal reflux, there are formulas that are helpful, but you have to distinguish from gastroesophageal reflux disease, what Joseph already addressed. So there are two different entities. The one is a disease, and the other one is when the baby is doing very well and just spitting up. And you have to distinguish between these two conditions. And if you have gastroesophageal reflux disease, you have to see a pediatrician or a pediatric gastroenterologist. And concerning the constipation, there is basically no evidence that any formula helps.
No, thank you very much. I think maybe a last question, because it's addressing to Joseph, to you. Thank you for a great presentation. Even though we are now advancing enteral feeds faster, would you still recommend a maximum increase of 20 kilcal per kilogram a day? How this was published in 1999?
Yeah, so there have been subsequent papers that have been published in this area, and one that comes to mind is a study from the UK that was just published in New England Journal a couple of years ago, where they compared 19 milliliters per kilo per day advancement versus 30, and they found that 30 is that does not increase the likelihood of development of any kind of gastrointestinal disease. You can get the babies off of parenteral nutrition much sooner. But again, I think that the point of my lecture was that one size does not fit all. And certainly if you have a baby who is at 24 weeks gestational age and you are trying to advance feedings and the baby is on nasal prong positive pressure ventilation, that baby is likely to have some abdominal distension, and you don't want to push those babies too fast. So I think that you want to individualize your approach at this time to, for some babies, you're not going to give them 30 milliliters per kilo per day advancement, just because that particular study looked at the average, okay? And that's one of the points of my lecture, is that we want to be able to get away from just looking at babies who are the average. We want to look at both sides and be able to provide personalized precision nutrition for all babies, not just the average.
No, thank you very much. I think it's even a good summary. We need to go to individualized solutions. We need to see each preterm kind of a single individuum and maybe to make some decisions. I would really like to use the opportunity again to thank you very much, Joseph, and thank you very much, Nadia, for making you available for this very interesting webinar, and of course to all the people that were watching us, that were listening to us. I think it was a very interesting new aspects in both presentations. Presentations are recorded, will be available also for further watching, and also to invite other people to have a look on this really interesting presentations. On my last note, please, also on behalf of Nestor Nutrition Institute and W Nutrition and Science Center, please provide us also with the feedback. You have a link where you have feedback questions that we can always improve, because we are here to organize such kind of webinars for you, that you learn from them, that you get very inspiring information. As I said, 10% of the babies are preterms, and it's really important that we take special care for them. And I would really like to thank everybody for doing that each day, 24 hours, 7 days. I wish you all the best. Stay healthy. Thank you very much.
Thank you.
Thank you.